Welcome everyone to our workshop this afternoon, MAID, the ongoing impact on service providers, where we'll talk about the understanding of the process of MAID, navigating potential personal conflict, and processing the emotional impact. This webinar is provided in partnership with Casey House and the Ontario HIV Treatment Network. My name is Thomas Egdorf. I'm the Education Coordinator here at Casey House. And with me today is Tanya Oxum and Diana Campbell from the OHTN. And before we get into the workshop, I just wanted to do a land acknowledgement. Please join me in acknowledging the traditional caretakers of these lands and in appreciating their graciousness in allowing us to carry out our important work across them. As we do this, I recognize their inherent Indigenous rights entitled to the lands that we live on. Most of us are located somewhere in what we now call Ontario, a place that predates this name and has remained home to many First Nations, Métis, and Inuit peoples. I acknowledge the original inhabitants of what we now call Ontario and the many distinct groups of First Nation peoples, each with their own language, customs, and territories. Acknowledging this recognizes the significance of these territories for the Indigenous people who continue to live upon them and whose practices, culture, health, and spiritualities continue to be tied to the land. In the spirit of truth and reconciliation, we must challenge ourselves to disrupt and dismantle colonial structures that have caused immeasurable harm and systemic inequalities to Indigenous people. I challenge each of us to seek truth and to disrupt anti-Indigenous racism in HIV work and beyond, in policing, in the criminal justice system, in healthcare, the child welfare system, and in our day-to-day lives and relationships. And now I will introduce our two wonderful presenters today. For anyone that attended the session that we had in November, we welcome back Jeff Myers, who has been practicing palliative medicine for the past 25 years, is an associate professor and current Brevner Family Chair in End-of-Life Care and Medical Assistance in Dying at University of Toronto's Department of Family and Community Medicine. Within the Telemetry Faculty of Medicine, he is clinically based at the Hennick Bridgepoint Hospital's Albert and Tammy Latner Palliative Care Unit and is the academic lead for the Tammy Latner Center for Palliative Care. Also with us this time, I'm very pleased to introduce Brenda Stein, who has been a social worker for almost 41 years, graduated from University of Toronto, has been at the Hennick Bridgepoint Hospital and its many iterations since 1995. Prior to this, she worked at Queen Elizabeth Hospital in Baycrest and briefly in private practice. She has been affiliated over the years with the three Toronto universities, but primarily U of T. And Brenda is at her happy place when she's at Bridgepoint Hospital. Please join me in welcoming both Jeff and Brenda, and I will turn it over to you two.
Thank you so much, Thomas. Very much appreciate the invitation. 41 years, Brenda. I didn't realize it was 41 years.
I didn't realize how old I was sounding.
Welcome, everyone. Thank you so much for joining us this afternoon. We're very pleased to be joining you, and that you'll be joining us. This very much does build on the conversation that we began in November, when we focused a lot on sort of the process and the details around how a person accesses medical assistance in dying, and sort of the structure of that. And what Brenda and I have been asked to speak to, and I'm so grateful that Brenda is joining me to sort of ensure that we give diverse perspectives, is a bit more the impact of caring for people that are requesting MAID. Let me just pull up my slides. So what we aim to kind of cover is, as I mentioned, sort of the impact on the wellness of care providers and teams through our interprofessional lenses of social work and medicine. We really want to make sure that by the end of this discussion that there's an appreciation for a range of comfort and conflict and even perhaps objection that individual clinicians experience when it comes to medical assistance in dying, how this can impact team function. And we'll talk a little bit about some strategies that aim to respect individual clinicians, promote team function, and maintain high quality patient and family care. We're actually going to get you to do a lot of the work for us in this session, and we've got a bunch of poll questions and more free text questions for you. But before we get into that, just a bit of an acknowledgement. Discussions that involve medical assistance in dying, Brenda and I have learned, can be challenging and can be tricky to navigate because of the complexity and the nature of medical assistance in dying itself. And we just wanted to start off the bat and say, there's many unanswered questions around how MAID care should be delivered, where it fits within healthcare. What are the safeguards? What is eligibility? There's many questions today that really remain unanswered. There are several populations that are known to be vulnerable that are potentially eligible, and there's several that are not. We'll talk a little bit more about that in terms of the details. But despite these unknowns, there are also several certainties. And the example is a person, a client that you're working with may want information, may raise MAID, may have questions around it. And it's much better for a team to work through the challenges ahead of time and talk through, what that might mean if a client actually raises MAID. And so that's really what we're wanting to focus on today, is sharing our experiences. Hope that you reflect and consider how your experiences and your teams could evolve, and share with you ours. Okay. I just want to I can see that there's a audio problem. Brenda, you can hear me okay?
Hear you.
Yeah, okay. So I'll leave that with Thomas and Diana then. But what we're going to ask folks is to join us at slido.com. So if on your computer or your phone, if you get into your browser and join slido.com, and where it asks you to put in an event code, if you can just put in MAID, we've got a whole bunch of questions that we're going to ask you. So it's slido.com and then putting in the event code MAID. Thank you, Tanya, put that in the chat for us. And so the link is right there. And I'm going to take you to our first question. You can see how to join is still on the slide at the left side there. But when you think about MAID for your setting, what worries come to mind? A couple of words or a phrase. This is very cool because you can see the people who are typing.
It's very cool. From a Luddite perspective, it's very cool.
And we know that 155 of you are there, and so we're hoping to get a number of responses from you. Let's see what folks are writing.
Oh.
So grief comes to mind. Let's start from the bottom and we'll work our way up. Cost efficiency, how to assist the person, that people will try to limit access for folks. Liability, strong differences of opinion, self-care, perception of staff, overprescribing, mental health of patients, that I won't have answers for clients. Death, people ending their lives because of just sadness and hopelessness, the vulnerability of the marginalized. Our unhoused folks do not have a safe place to die. Eugenics, interesting. Clients with mental illness, fear of dying, supporting people with anticipatory grief, support for staff and visitors. Client consent can be challenged. That's interesting. How to best support someone making the decision. Having power over life and death. Sorry. People being too quick to choose it instead of asking for better care,
Mhm.
lack of private space, grief, how to deal with knowing when someone is going to die and counting down the time. Well, that's interesting. Counting down the time. Judgment, the family's reaction. People will be discouraged by others instead of trusting themselves. People not having a real choice because of the systemic oppression they face. Example, homelessness, mental health issues, lack of care, disability without supports, abuse, deep poverty, lack of resources, availability for quality of life driving the decision to support, how the family will react, how to support, the mental health of the client during the process,
Mhm.
grief, structural issues that may underlie, judgment, will it be fast? Will it be painful? Whether it's painful or uncomfortable, relief, staff's experience throughout the process, fear, people opting for MAID because ODSP is not enough to live off of, and housing pressure, dealing with families. It's hard in every cultural background. Where to refer to access resources, grief, care, death, cost, meaning death, judgment, people who are living rough or unhoused, lack of privacy for discussions, lack of information, options. Wow, they keep coming. Thank you, everyone. Inaccessibility, perception of family, religious expectations, mental and emotional health. I worry about vulnerable people being coerced into seeking out MAID. Management challenging patient wishes, how best to support people with limited access, hopelessness, grief, liability. That word liabilities come up a couple of times. That's so interesting, Brenda. Religious belief,
Yeah.
that the client's autonomy won't be respected while having to go through that process. Suicide, loss, resources and support to provide. Difficulty determining eligibility of patients with substance abuse and mental health disorder. That's an important one, which we're going to touch on. Did they explore other options? Access to care. SDH, I'm not sure what SDH. We'll come back to that. Having informed decision of health condition, vulnerability, that clinicians' personal options biases will make it harder for people who need MAID to access it. Lack of training, compassion, legalities, how to support barriers, grief, uncertainty, unanswered questions, how to support family, worried about if clients will want access due to hopelessness.
Mhm.
Best time for MAID and long-term care, cultural beliefs, culture, an option that is offered first before exhausting other options, biases, religion, fear, cost, mental health, sorrow, uncomfortable, painful, and just the last few here, barriers at a faith-based hospital,
Mhm.
individuals who can support, forced to choose because other services are not available, grieving starts before death happens, and grieving for their community. Wow, thank you, everyone. Mental health is how reliable mental health is. So this really helps us and tells you who's here today with us, and what are the things that are top of mind. SDH, social determinants of health. Thank you very much, Stephanie. That makes perfect sense. The next question. So we've got then a series of questions for you now, that sort of get into, there are multiple choice questions. We'll just get into the first one. So how many of you have had, or how many clients with whom you've had a close professional relationship have died? So in the professional context, how many clients have you had who have died? None, a few, several, or many? We'll wait for 50 folks to put in their responses, Brenda, before we
Okay.
Oh, we're up to 54. Maybe we should wait till 80. We got to 50 pretty quick.
And who's counting?
There's a little top right corner. On the top right corner, you can see the count.
Very
Okay,
cool.
so let's go. So
Wow.
most of people have had, so about a third of you have had a few, a third of you have had several, and then about a fifth of you have had many, and a number of you have not had any professional relationships with people who have died. Okay, the next question builds on this. And how many clients of yours have requested information about MAID? Not requested MAID, that's going to be the next question. But this question is, how many clients have you had who have requested information about MAID? great that people are so engaging. We're almost at 80 already. Okay.
Wow.
So about half and half. Half of you have had a few and half of you have had none. So for many of you then, for about half of you then, this is quite unfamiliar. There's a lot of uncertainty, I would imagine, in this.
Be interesting to know. Well, no, I lost my question. Sorry, continue. 'Cause I'm
Well,
fascinated by this.
so I suspect I know the answer to this, but we'll put it out there. How many clients of yours have requested MAID? So rather than requested information, have actually gone ahead and requested MAID. So presumably that only half of you will, or at least half, or at most half of you would have had a request for MAID, because only half of you had a request for information about MAID. But let's see how many have actually had requests for MAID come their way. For those of you who are just joining, if you want to go to slido.com and the event code is MAID, you're welcome to join in, because we have a number of questions still to go.
Wow.
So still a third actually have requested MAID, have made a MAID request. And so we're going to be drawing on your experience around how that was for you and for your team, for those folks who have had clients who have actually made a request. So the next series of questions are a lot. They're not demographic type questions. They're much more reflective in how they build on each other. I want you to consider a client who's unwell and expresses frustration about the impact their illness has on their life. I would feel comfortable responding, whether or not you strongly agree with this statement or all the way down to strongly disagree. So you've got an unwell client who expresses frustration about the impact their illness has on their life. I would feel comfortable responding to that. Just give it another 10 seconds.
I'd love to hear the response of what would they be responding to? What would they say if a client said, I'm frustrated, I can't do what I need to do, or because of this illness? I would be interested to hear what their words were.
Well, I think we'll actually get into that. So interestingly, so half of folks would feel comfortable just responding to somebody who's expressing frustration about
Yeah.
the impact of their illness. So let's take it the next step, folks. How about if a client expresses a strong sense of hopelessness about the impact their illness has on their life? Would you feel comfortable responding to that? So taking it beyond sort of frustration to the next level, which would be a sense of hopelessness, a strong sense of hopelessness about the impact of their illness. Would you feel comfortable responding to that? So I think we had half on expressing frustration, Brenda.
Mhm.
Just another 30 seconds. Okay.
Wow.
Interesting. Okay. So actually more would feel comfortable responding to a strong sense of hopelessness. Oh no, actually it was strongly, let me just actually back up really quick.
Wow.
So the strongly agree was 50%. And then for this one, agree was a little bit higher at 60%. Okay. So then the next question takes it to the next level. If you've got an unwell client who expresses the sense that life is no longer worth living, or they cannot continue living because of the impact of their illness, I would feel comfortable responding. So again, moving from a sense of hopelessness to a level of a client actually expressing the sense that life is no longer worth living, or they cannot continue to live because of the impact of their illness. Okay, let's see what we've got. Same half, okay? So I suspect we're actually circumscribing different groups of people in terms of their exposure, perhaps, Brenda, to this and
Yeah.
comfort level. But here's the last in this series of questions. If an unwell client expresses a wish for MAID, I would feel comfortable responding. So taking it to that next level, an actual request for or express a wish for MAID. So really, I suspect a consistent group of folks either agree or strongly agree with the comfort in responding to these things, and then a consistent group around not being sure and disagreeing. And so we're really going to hopefully speak to both groups as we kind of move forward. Thank you, everyone. What we want to do is in a good chunk of time, we'd like to make sure that it is your time well used. And so we want you to reflect on the question, what information about MAID would be the most helpful to you in your practice? This can be about eligibility, or it can be about the procedure itself. It can also be about questions that you might have about MAID related support to clients or teams. A number of you made comments in that initial sort of question around, what what are your thoughts or feelings around this? So, we're going to take some time and just kind of go through some of the eligibility, new updates on the eligibility. And then we're going to come back to this. In the meantime, please do enter the questions that you have, the information that would be particularly helpful to you in your practice. And, after we finish the eligibility slides, Brenda and I are going to take some time and really go through, the parts that you would be helpful to you. So please put some thought to what information about MAID would be the most helpful to you. We've got a range of folks around their comfort level, with us today. And so there's no information that won't be helpful to someone. So please feel comfortable in letting us know what information would be helpful to you. Before we get to that, though, we just wanted to kind of give you an update. Okay, Brenda, okay if I keep going? All right.
Thanks.
We just wanted to give folks an update from November because there's been a number of things that have happened, I think, eligibility wise. But just to kind of make sure that we're on the same page. So as it stands today in Canada, to qualify or to be determined as eligible for medical assistance in dying, two clinicians need to agree that a person is eligible. It can be a physician or a nurse practitioner, and they must meet these 5 criteria that are listed here. Be eligible for publicly funded services, be 18 and have the capacity to make a MAID decision, that the request that they're making is voluntary and not a result of external pressure, that they've provided informed consent for MAID, and that they have a grievous and irremediable condition. This last point is what there's been some changes recently. How grievous and irremediable condition is defined is a serious or incurable illness, disease, or disability with an advanced state of irreversible decline in capability and enduring suffering that is both intolerable and can't be relieved under acceptable conditions. Now, prior to 2021, just to remind everyone, natural death being reasonably foreseeable was also a criteria that was required for eligibility. In 2021, the updated federal legislation revised this and removed natural death as being reasonably foreseeable as a requirement. But it created, what the government did was create 2 tracks of eligibility for MAID. Those who have a natural death that is reasonably foreseeable is track 1, and those whose natural death is not reasonably foreseeable as track 2. And there's some very different processes. We got into the details of this in November, so we won't get into the details, but suffice to say that a person on track 1, their death is reasonably foreseeable. That person can be scheduled for MAID at any point once they've been determined as being eligible for track 1. As opposed to track 2, there's a 90-day reflection period that a person must have if their death is not thought to be reasonably foreseeable. And there's some very specific tasks that need to be accomplished during that 90-day reflection period. For example, getting to an input from a specialist in the underlying illness that the person has to make sure that they've been offered or aware of all of the treatments that are available. An example, well, I won't get into the example because I think that probably gets us off track. But just to say that there's these 2 sort of tracks. Why this is important is that in
November of 2023, when we last met, when we had our first session, there were some potential changes, in particular mental illness, as being the primary underlying condition that was going to move forward in March of 2024. It has not, and we'll get to that in a moment. What I wanted to first point out was a little known sort of legislation that went through in Quebec in June of last year. And the Quebec legislation actually took mental illness as the sole underlying condition off the table completely for Quebec. And for as long as, until it gets challenged in court. So prior to Canada taking it off the table, Quebec took it off the table. At the same time, this bill in June 2023 in Quebec made legal advance requests. So people who are worried about dementia and are wanting to proceed with MAID if they get to a certain condition, set of conditions, they would want to have MAID. That's called an advance request. That is legal in Quebec. It is not legal in Canada and the rest of Canada. But it's one of the three groups that there were outlined, there were lack of clarity as to what was going to happen. Mental illness being the underlying condition, one group, advanced requests being the second group, and mature minors being the third. So in Quebec, advanced requests are actually legal. The other thing that they did in Quebec was make institutional conscientious objection not permitted. So religious-based organizations or hospices, as an example, are no longer permitted to not permit MAID on their premises. They must in Quebec, they must have a plan for how they would support their patients. So that really actually informed a lot of what happened at the federal level over the last couple of months. And so that's why I spent some time here. So just to Brenda and I wanted to kind of address this before we turn it over to kind of the information that would be helpful for you. Mental disorder being the sole underlying medical condition. And originally that was supposed to come forward in terms of eligibility March of 2023, which was delayed until March of this year. And we learned in March of this year that it's further delayed until 2027. I will go out on a limb here and say this is very speculation, and it's my opinion. I would be surprised if it does move forward in 2027. And in large part because of what Quebec did with their bill, and in large part, I think, because of the complexities around mental disorder as the sole underlying condition. The decision to delay until 2027 has been met with widely mixed response across the country. And I will say that I'll speak for myself, and Brenda, you can chime in. It is not an area of expertise or familiarity or comfort or knowledge for me personally. And I think, Brenda, you're shaking your head, you would agree with that.
You know what? I don't think I could even possibly go down that road. No.
These are highly, highly complex populations, and how you differentiate something like a MAID request from suicidality, how you address a schizophrenic who has some delusions, and how you would tease apart an addiction and a request for MAID. These are really, really complex scenarios, and I think that's why it was delayed. It's been delayed a couple of times now. It's not gone well in other countries that have moved forward with mental illness as a sole underlying condition. In the Netherlands and Belgium, as an example, they didn't actually have a qualification for it not to be at the outset, and so they have very few cases of people who have met the criteria. So there's not a lot of experience or data to draw from. We wanted to just point this out as a population that many of you would have curiosities about, if not even experience. And unfortunately, we have very limited experience with that, I think, for many reasons. Okay, so we wanted to kind of turn it over to the folks that have kindly sort of put some info and thoughts in the chat for us. And I'm just looking, I can see a couple of questions now here, Brenda, and one in the question and answer. Let me start with the questions that are in the chat. So remember, for anyone who has a question, please do enter it into the chat about what information would be helpful, most helpful for you in your practice. The first question that I see is can a person who is deemed capable and has a dementia diagnosis be eligible? So that's a great question.
Wow.
So when a person is diagnosed with dementia, that does not say anything about capacity to decision make. The first thing that I would say is that capacity to make decisions is decision specific. So there's going to be a person, regardless of what their underlying illness, you have to assess capacity for that specific decision that's being asked of them in that moment. A person who has been diagnosed with dementia doesn't automatically lack capacity, I think is the first thing to say. The next thing I would say is that could a person who has been diagnosed with dementia be determined as eligible for assisted dying? Absolutely. They could absolutely have the capacity to make that decision and not have lost enough capacity to not make that decision. The challenge for a person with a dementia diagnosis gets to the reasonable foreseeability of their death and that notion of an advanced request. The reality is that a person who has a diagnosis of dementia and still has the capacity to make a decision around MAID would probably need to pursue the procedure earlier than they would typically like to have, because they would need to have capacity when setting a date is really what it comes down to.
There's a time frame for that, right?
Say it again. So
There's a time frame kind
yeah.
of to do that.
So the specific process is that if a person who has dementia says to me, I would like MAID, and we get the assessments and the person's found to be eligible, at that point, a date needs to be set for the procedure. If the person loses capacity between then and that date, it can still proceed, but it can't be sort of, when you set a date, you can't say 2028, right? Like as the date that you'd like to proceed. So it's an important point because people are trying to think about workarounds for dementia. And if the system and the process is handled appropriately, there really isn't a workaround. You need to set a date when you are determined to be eligible. So it's a tricky question, but the short answer is, can a person who's deemed capable and has a dementia diagnosis be eligible? Absolutely, they can. They may have the procedure earlier than they would ideally have it, because they may not be at a place in their illness that is very, very advanced, but a person can proceed with it. Maybe we'll go to I'm not sure if the one above it is a question, but these are the topics that are coming up. I'm curious to know if there are barriers in place for people who use drugs and meet the eligibility criteria for MAID. Is informed consent impacted? Does drug use impact capacity to make a MAID decision? Will the client be able to access locally if they are currently in a smaller community? So we'll tackle the first one, which is, does drug use impact capacity to make a MAID decision? I would, and Brenda, I'm certainly, curious as to your take on it, but I would say, much like any illness, if capacity is impacted, it's impacted, and a person won't be eligible for MAID, regardless of the underlying reason for capacity being impacted. I could have an infection throughout my blood, and that could make me confused. My capacity would be gone to be making a MAID decision, much like it would be if I were, under the influence of drugs. And so I think, as it comes to assessing capacity to make a decision, it's irrespective of why a person may not have capacity. If they don't have it, then they're not eligible. Anything to add to that, Brenda?
No, I would totally agree. I don't
Yeah.
think I don't think it's why they don't have capacity. It's
Yeah.
have capacity or you don't.
The complexity is if the underlying condition that the person is seeking to proceed with MAID, if the underlying condition is the addiction, that's when it becomes complex. And as it stands right now, it's not legal for a person with an addiction as their primary illness to proceed with MAID. Okay, so we've got some questions over in the, thanks so much, Tanya. We've got a bunch of questions in the Q&A. So can a health care provider be a witness? Actually, you know what? I'm going to take this off the slide, Brenda. So we're looking at each other, and then I can put the slides back when we need to. So can a healthcare provider be a witness to the request if they are not an assessor? I've been advised not to do this, but my understanding is the legislation changed for this reason. Example, not to be a barrier. The short answer is yes. A healthcare provider can witness a request. And in fact, actually, if you are the witness to the request, you cannot also be an assessor. And so that is new in 2021. It used to be that witnesses could not be healthcare providers. However, that's changed, and it's made it easier for people and easier for folks to actually get an assessor, or sorry, a witness for them.
The
Go
whole
ahead,
MAID
Brenda.
process, not to interrupt you, but
Yeah, no.
evolved, substantially from the beginning of when it began. So we've seen it kind of, it's much easier in a lot of ways, and there's a lot less drama. When it first started, the very first time it happened, certainly in our hospital, it was huge. Like I can't even tell you how big it was, and there were a lot of, pardon the expression, a lot of suits floating around the unit and involved, and the to get in, we needed an interpreter for that the very first one. The woman only spoke Chinese and really just could indicate that she wanted MAID by saying, I don't even know the bill number. She would say C13 or C14 and go like that. And there was a lot. Now there's less obstacles, and it's a much easier process, I think, for people, if that helps.
There's a couple of follow-up questions on the addiction that I think we'll address now. One is, what if the addiction is the cause of the primary health condition? So liver failure as a result of alcohol or drug use. So that's a great question.
Yeah.
So, if the person's if death is reasonably foreseeable because of the liver failure, and the grievous and irremediable suffering that the person is experiencing is because of the liver condition, then the underlying reason for the liver condition shouldn't matter in my view. So it may be that alcoholism is why the liver is a problem, but as long as the person has capacity to make the decision, and that the suffering is related to the underlying liver disease, then it doesn't matter actually how the liver illness became.
Kind of like lung cancer. You've smoked all your life and you end up with lung cancer, and so you haven't lived a life of such great health or whatever, and you end up in this situation. It's the same premise.
That's right. There's also one over here. I think it's a question. I've encountered a situation where a client was known to be in a permanent long-term meth psychosis and was approved for MAID, and everyone involved did discuss the drug use, and the client avoided any situation where they may be drug tested. They had terminal cancer, but was ignoring their mental health and drug use to make sure they got approved. I think that we I certainly can think of a couple of cases and scenarios that have made me feel uncomfortable. And hearing the story is an example of one, right? Where it, it doesn't feel quite right. And so the I think the most important thing is for us to be having conversations like this. And so each of you has some information and has some resources, so that if you do encounter a situation where it doesn't feel quite right, that you at least have a place to go, or something to, a resource to go to. There's another follow-up question from Dan. Why does the substance use matter? I think that the only time it would matter is if the underlying condition that the person is seeking to proceed with in medical assisted dying is substance abuse. Otherwise, if it's related or unrelated, the substance abuse doesn't really matter. I agree with you with that question. Okay, so another question, Brenda. How to discuss with colleagues, volunteers, and family supporters that may be against MAID, or not support the person choosing it? That's a great question. So colleagues, volunteers, family supports who are against, how would we address that?
Again, that when this first started, there was so much drama, and we actually met a lot as a team, and discussed the MAID or the upcoming MAID and the emotions that we all had. There's something that has happened over the years, an evolution in the process. It's not to say that we've become kind of
Immune.
complacent with it, or we've become numb to it. We've come to kind of live with the idea of it, and it not to make, and we've always been afraid to make it a routine event, because that diminishes kind of the importance and what this is really about. But there's been issues. We've had families that have not agreed with the decisions someone is making. But it's our job. It's my job, and Jeff and I do this a lot together, and it's our job to help the family move towards it. You don't have to accept it. You have to accept the decision that the individual is making. It's not always our choice. It's not our choice. So in every situation, it's not just MAID, it's everything that we have to work with a family or a friend or a relationship that doesn't always fit with what they think about. That's our job, to kind of work with that situation. It's a process, I think.
One scenario that's happened to me frequently is the person who's having MAID doesn't want the family to know. Which is sort of an interesting twist on the question. And I'm curious as to your thoughts on that, Brenda. Sort of, the approach to that. There's actually only been one person that I can think of who maintained that, and everyone else, and there's been many of them who were very reluctant to speak to their family. And a few I've in the moment needed to get a little bit clear with, about the complexity of not sharing with family. Do you have thoughts on that, Brenda?
You know what, maybe just because of growing up or being grown up now, I just think people come to us at a point in their life that they've lived a life in a specific way. They've had relationships. They're not just a patient in room 123, or they're not just a patient in a terminal situation or whatever it is. So they've made their choice, and I think we have to we evaluate their capacity to make that decision always. I think in my head, I'm thinking, is this person rational about, and is this person clear about what they're saying? Don't let my family know. You can, I know there was a gentleman in another unit. You can call the person after and whatever, they'll know. Like, it's not our walk, it's not our journey. We're not lying in a bed, we're not dying, we're not in this situation. I've come to kind of see it in a different way. But we have to put on our clinical skills to see whether they can make that decision.
You know, I completely agree with what you're saying, and what I think is important, and where the skill in it, you're right, is in teasing apart what's fear-based and more sort of fear of the unknown, and the the resolution that can happen when there are discussions with family, versus the trauma that can happen if there are discussions with family. And so you're right, it is that's a nuance of this that that is really tricky. But I put it out there just because it may be something, since half of you know have actually had these requests. These are the kinds of things that you'll run across then, for sure. Next question is, do you foresee any role for allied professionals' involvement in MAID with the goal of improving decision-making and expand care for clients? That's a great question. Brenda, what are your thoughts on that?
Of course, I'm not sure in what way, but certainly allied professionals in our situation on a palliative care unit are often involved in the situation. But I also have to, I think a lot of you are in the community and in a different situation. There's not always, what I've learned over the years, there's not always a role. Not everybody needs, I often say this, not everybody needs a social worker. What, I don't want a social worker. I've made
That's on your advanced directive.
but we have to, I think allied professionals provide a different perspective.
Yeah.
And kind of fill in the entire person and their system and what's affecting them. Somebody talked about the finances and their socioeconomic kind of situation and what can we resolve in order for them not to be in this kind of thinking.
Suffering. Yeah. And I would add to that sort of function, right? Like that's where I've seen so many of our rehab, and it's one of the benefits of being at a rehab hospital and acknowledging that folks in the community may not have the kind of resources that we have here, but the expertise of our OTs, our PTs, our SLPs, our recreation therapy professionals, and the impact that they have on people suffering is really quite profound. And so I think there's an important role for our professional team members all around. So the next comment, I think Brenda, just checking in. You're doing okay? We're doing all right. All right. I would like the procedure of MAID demystified. My workplace has people receive MAID, but as we are not the providers that carry it out, we are often not 100% sure of what happens. I would be interested in the info surrounding the procedure. Oh, that's really interesting. You know what I would say to the person who offered that, I think it would be okay to ask if you could participate if you're at a place where they're actually happening. I'm just thinking about where that is, or what that might look like, or if you are interacting at all with the people or the clients. If you are, then I would think you could ask for it. But very, very briefly, it's a very straightforward process. In that medications are injected. The whole thing lasts about 4 minutes, and I often sort of say to people, it's kind of a non-event event, in that the first medication that's given is a strong sedative, and so the person is asleep, and within the series of medications that are given afterwards, they stop breathing, but it's a very quiet process.
I
Yeah, please.
from a non-medical person,
Sure.
an extraordinary experience to
Yeah.
observe the kind of the moment between life and death. Like to me, uh, I'm awestruck, truthfully, by the fact that somebody is there and very cognizant and very aware of their situation, and then not, and they are gone. And because even being a palliative social worker, I don't sit by the bedside and watch somebody die very often. It's not, to take their last breath, but to watch this process, it's extraordinary. And um to see kind of, it's just, I'm pretty awestruck by certainly Jeff and our doctors, the capacity to do this with such kindness and humanity. I kind of I've come to really I don't know, not admire the experience, but I'm pretty struck by it. It's not as scary, but the other thing is that I make sure, and I know Jeff does the same, to explain the process very clearly to the family or the people that are part of it, and to the patient. The patient is usually kind of from my point of view, they're not worried about anything at that
Yeah.
point. The family are worried, are they going to froth at the mouth, or what are they going to experience? And I have a philosophy is the more information anyone has, the more control they have. So I think the more they know, the better it is for them.
Nicely said.
Thanks.
I get into the process of it all, right? So I really appreciate that perspective, Brenda, because it's when I'm walking home that day, or when I go for my walk afterwards after a procedure, that's when I'm struck by the bigness of it. In the moment, I tend not to be, because I'm so focused on what it is that's actually happening. You're gonna say something else? Yeah.
I also just want to add that I think we have a practice that our physicians are not just parachuted in
Yeah.
to do the procedure. To call it a procedure is it's not
Weird.
it's
Yeah.
a dumb term to me.
Yeah.
But our doctors, like Jeff, knows that person, is familiar with that person, has a relationship with that person. To float somebody, a stranger in, like just to do, is not okay. I think there has to be a relationship. This is the most human thing to be doing in a lot of respects.
Yeah, and I'll just add one point to that. There's some institutions, because there's a couple of questions coming up around institutions and palliative care teams and things like that. There's some institutions that have a separate MAID team that is consulted, when a person makes a request, and would actually go through the process of assessing and then actually providing MAID. Sinai Health, which Bridgepoint is a part of, we do not have a MAID team. And, that was, I think, a fairly deliberate decision. And I know for myself personally, I'm very grateful for that, because it means that I'm not handing it over to someone else, which I can't imagine doing. I also can't imagine doing a procedure for a stranger, and wouldn't. So that's my professional. Those are my red lines. When it's somebody that I know, that I've come to know the story, that I see how it's unfolded, then I'm comfortable. But if not, then I won't. And I have great respect for my colleagues who identify as MAID providers, because this is, a big part of their practice, or even the sole part of their practice. For me, it's not the sole part of my practice, which I think leads into the next question. How does MAID relate or connect with palliative hospice care? My understanding is that hospice programs are reticent to facilitate access to MAID, but could be wrong on this. No, you're not wrong at all. Brenda, I'm curious as to your take on this. My few sentence summary of this was, initially MAID was only available to folks whose death was reasonably foreseeable. And so who were nearing the end of life. And there were lots of assumptions that palliative care would just sort of subsume MAID. And palliative care was not at the table to make decisions around how this was going to roll out clinically. And the other, I think, important historical piece of information is that other countries, when they moved forward with their MAID legislation, they at the same time moved forward with ensuring access to palliative care. Canada did not. And so a person could have access to MAID, but not access to palliative care. And that made a lot of folks in the palliative care hospice community quite uncomfortable. So these things made for a relationship to be difficult and challenging at the outset. I would say that that's evolved tremendously over the last few years. And there's most hospices now are changing their policies as a result, or as a result of the evolution of it. But Brenda, I'll turn to you.
I'll just say a couple of things. When MAID became legal, and I remember sitting in a car with my friend and we had coffee, and she goes, well, now you're going to be really busy. And I go, don't be ridiculous. This is not part of palliative care. If we do our job right and well, people are comfortable and they die comfortably. I never imagined, and there was a conflict, an internal conflict initially for me and for many of us, I think, going, if we're not doing our job right, allowing people and providing a comfortable death for people in a beautiful unit and they have to choose the immediacy of MAID, what are we doing wrong? And we questioned ourselves a lot. I don't know how I've evolved. I think I've grown up is really the truth. But I've seen that how we approach a patient who requests MAID is we explore. Jeff and I have often, I have a vision of a room with a gentleman. I can see him across my office. Knows who I'm talking about.
Yeah.
And exploring the different pieces of that. What could we do that would make you more comfortable, that would give you the quality of life, or is quality of life no longer part of your in your mind or whatever? Like we've explored, I think we try and exhaust the possibilities of life. But it's been an interesting evolution. The whole process has been an evolution, and I guess maybe a growing up for all of us. I don't know.
I want to pick up on that, but just want to check in with Thomas and Diana because I see that we're at 3 o'clock and make sure that we're okay just to continue in this format.
I'm sorry.
No.
Yes, absolutely.
Okay.
I'm going until 3:30 today.
Okay,
so
great.
We still have
Great.
30 minutes.
So the one point I wanted to build off of that, Brenda, is the majority of times now that a patient brings up MAID does not result in a MAID procedure. That I think what MAID has done is give Canadians, given citizens, given the public a language around suffering. And so we will frequently have people that raise MAID as a way to signal that they are suffering, not as a formal request. And it is what makes me worry for folks that maybe have less experience and would sort of take a request at face value. And so I encourage, just to pick up on Brenda's point around exploring, is that often when you explore a request, you'll uncover the fact it's not a request, that a person's not actually requesting MAID. And so I wanted to put that out there for folks just to reassure you that if you do have a client that raises MAID, at least in my experience over the last couple of years, there's a very good chance they're not actually requesting MAID.
And
Do you want to add anything?
Control. MAID, to me, that is equal to control. It is controlling, the minute that person was diagnosed, that the minute that doctor, it's always the doctor, gave them that diagnosis and that to say you are going to die from this, they lost control. They were on that track that they had no choice to be on, but MAID and the ability to use MAID as a decision making for their future or whatever has given them back control. And that's, to me, that is the answer. So what can we give them in lieu of control? Like, what else can we offer them? And if there's nothing, then nothing it is. Then MAID it is. Like we're not going to push somebody.
Yeah. Next question is, who's responsible for the capacity assessment? And that is the people that are assessing eligibility are assessing capacity. It's not the role of the witness, I don't think, to assess capacity to sign the form. You're only witnessing that this is the person who says they are with their signature. So the actual capacity to make the decision around MAID are the folks that are the physician or nurse practitioner who are doing the eligibility assessment. Okay. Next question, is it a type of suicide?
Huh.
So very 5-6 letter or 6-word question, but a really tricky one. Again, this comes back to not being a mental health expert. I will say that what I've learned, I think, in conversations in preparation for mental health being the underlying condition, and all of the discussions that went into preparing for that even though it's been delayed, is that a suicidality is is sort of an erratic, impulsive moment that a person would have that has an irrational component to it. But that's my very basic understanding of it. What's different about a MAID request is that it's not from an underlying mental illness that is bringing a person to suicidality, which is what I've always thought of as suicidality, but I may have that wrong. The person that makes a decision about MAID is not, it tends to be unwavering. It is, and there's a calmness about the decision as well. It's not an erratic, irrational thing that someone comes to. There's a sense of relief that a person experiences when they make this decision and they communicate it to us. But that's been my experience, Brenda. I wonder if that's been yours.
I would agree that there is a surety, there is a calmness when somebody makes that decision. But I think there is that idea, I like the question about suicide, and there is a perspective that people have, and even within the professions, and even within the hospital, that you're aiding and abetting suicide, basically, and what do we do with those beliefs? And maybe we each have our own beliefs. I think it's an extraordinarily brave thing to go through this process, and a rational kind of decision to say, I want MAID, I'm done. I often talk about if there was a white flag on the bedside that people could press saying, Uncle, I'm done, that's what would happen. So there's a difference between, I think, the rationality of a MAID decision and a decision for suicide. So that's one issue. But how do we as professionals, I think, wrestle with this entire thing? I think that's another section of our discussion, kind of, what do we do with our own personal beliefs? And when I go home, necessarily have a discussion with my family about what I did that day. You know, I was involved with the maid. I stopped doing that because it's not something that's comfortable in my own world, because maybe in my world, the people that I love see it maybe as assisting and aiding and abetting suicide. How do I work in that? You know, so that's another piece of the discussion.
Thank you for sharing that, Brenda.
Sorry.
No, it's not straightforward. It's not straightforward. Can someone with severe mental illness, including multiple suicide attempts, access MAID? The person has tried multiple treatments unsuccessfully. If mental illness is the sole underlying condition, no, they cannot. That makes them ineligible. And that's what was delayed in March of this year until 2027, and it may be indefinite. Next question, what are the typical timelines from initial request through the process, through processing the application to administering MAID? I think a lot of that, so there's two things that depends on where you are and what track you are on. So if you're in that track one where your death is found to be reasonably foreseeable, then it's a matter of logistics, to be honest, because technically it could be scheduled that same day. If you had two assessors who both feel that the person is track one eligible, it can be scheduled at any point moving forward. And so then it becomes a matter of logistics. And that's going to differ by where you are. So in our hospital, you know, it's usually several days before we're able to get the things organized. At home, it can be a less, it can be more, depending on what's going on. So it's a matter of logistics when it comes down to once the assessments have been completed and a person is found to be eligible, and that differs by setting. Anything to add, Brenda, to that? Okay. I was asked to be a witness, but the client became so abusive that us two caregivers had to walk away knowing that MAID was getting closer. We gathered outside the hospital when we knew it was happening to support the family inside. I struggled with turning away in order to protect myself. You know, I think what's really important in this example, and thank you for sharing that, is there has to be a clear set of what you're comfortable with. What are your own personal and professional boundaries in this? I said, you know, I shared mine that I need to know the story. I need to be familiar with the story and be comfortable with the person in order to actually be the provider. And certainly, you know, I think there's going to be circumstances that are just outside of your comfort zone, and it's okay to remove yourself in the way that that you need to, and yet still support the family, which I think is lovely that you were able to do.
I think that's a great thing to do. I think you have to set your own kind of boundaries of practice always. And
yeah,
that's all.
Yeah. A reflection on trauma. If liver failure and lung cancer, referencing back to the previous MAID examples, alcohol or cigarettes may be the underlying risk factors, but still not the root causes, fair point, which may be trauma. No separation in the individual of physical and mental health, just sequential life experiences really could be said of so many conditions of daily living. The social determinants of health that often get blamed as unhealthy lifestyles, comfort eating as coping as an example. Those are really, really great points. Thank you so much for sharing. I am a MAID coordinator, and we have had pharmacy students, PSWs, and nursing students in 10 provisions. We asked the patient or family or consent. I think that probably was put in when the person was saying that at their institution they have them, but had questions about what actually happens. So thanks so much for sharing that, and that's great that I will say families and patients tend to be quite open to students, open to others having this experience, and that, you know, I think it's fair to ask, and they'll say no if they don't want them. In 2016, I was diagnosed with stage 4 cancer and given 6 months to live. Had MAID been an option, I probably would have opted for it. And now I'm here 8 years later. It's hard for me to take the medical expectations given to a patient. I support the process, but I would struggle with the decision if faced with it in the future. Thank you so much for sharing that. You know, I one of my other hats and interests academically is sort of serious illness communication and the problems with prognosis. And what I try to teach all of my learners is to never, ever, ever give a specific time frame to a person, because what happens is they go and circle that date on the calendar in a big red marker. And your point around having been given that time frame and had MAID been available is really important and well made. And I think it comes back to the critical importance of clinicians ensuring that we're meeting information needs in an individualized way. And that should never be, you have 6 months left to live. It just shouldn't. So that's my soapbox on that. I will leave it at that in the interest of time. But it's a real problem. It's a real challenge because my colleagues are sort of hell-bent on giving that kind of information. Do patients admitted to hospital receive MAID any quicker compared to patients requesting this in the community? No, I would say, in fact, it's probably a little bit longer because of the bureaucracy and the number of folks that need to sign off and all the rest of it in institutions. Agree? Everyone should have the right to request MAID and assessment regardless of answer. Well, they do in this country of ours.
Yeah.
It would seem there are a lot of questions around people who are living with addictions and other barriers to care. Have there been any advancements to be inclusive of all populations and meet them where they are at? Many defer healthcare facilities as a result of poor experiences in the past. I guess I'm not sure, have there been advancements to be inclusive of all populations? Have there been advancements in terms of eligibility for MAID to be inclusive of all populations? I would say actually no, because the three populations that there were question marks around: mental health as the underlying condition, advanced requests in mature minors, there isn't. The only movement has been the first, and that's been a delay for 3 years. So I think that's where we are, in Canada today. Trying to see if I understand correctly, since my internet connection is unstable now and I'm missing pieces. A person with a mental health condition only would not be eligible for MAID. That is correct. A person who has to have a physical condition that is causing life to be physically and emotionally unbearable after all treatments have failed would be eligible. Yes, that is correct. When mental illness or mental health condition is the only underlying condition that a person has, then they are not eligible for that being the grievous and irremediable condition. And lastly, what if there is mental health condition for which doctor has said is untreatable? Will the client be eligible for MAID? No. If mental health condition is the sole underlying condition, then no, the person is regardless of treatability is flat out not eligible in Canada as it stands. So that we made it through that wonderful list of questions, Brenda. And I've actually just got a couple of slides to finish us off in our last few minutes. So that's sort of perfect. I think we've gone through kind of the historical perspectives in our hospital, how it's evolved. Maybe actually, if we could talk for a minute about any internal conflict on the team, and how that's evolved, and how conscientious objection on the team is handled, Brenda, for a minute.
I was thinking about that because there are people that do not believe in this, that they. And at the beginning, there was a lot of discussion and a lot of judgment by the team members that were participating in the procedure, in the MAID procedure of the moment. That has evolved again. I think it's what we used to. The drama was so extraordinary, because we would wait for weeks for the procedure to happen, and it was many of us didn't sleep for weeks, waiting for the procedure, because there was a very big time period in between. Now we don't. We have I have wonderful doctors that I work with, believe it, I really do. And there are some that really have a conscientious objection to the procedure. But they understand it. They accept other doctors for dealing with it. They accept other team members. There is an acceptance and an understanding of it. I don't think um, I I don't think that's an issue anymore for us. I think as it evolves and as people become more and more comfortable with the idea of it and recognizing how there is a humanity to this process, I think that's important too. Does that make sense? I don't know.
Yeah, it did. No, that made great sense, Brenda. Thank you. I think what the other piece of it is that it's absolutely okay for people to conscientiously object, right? Like the culture that we have on our unit is that in the same way that a person has a conscious person with a conscience objects based on their conscience, in the same way that that person appreciates me in the role that I play, I appreciate the conscientious objection for that person. And so there's a mutual respect and understanding. And the other thing I would say is that conscientious, it's not binary. There's a whole range of what people are comfortable with and not comfortable with. And so it's not one or the other. You're not pro-MAID and anti-MAID. There's going to be a whole range of comfort and what a nurse, for example, will be, how comfortable they are in caring for the person in the days leading up to a person's procedure, and that can range. And so it really is about conversations as a team, creating the space and the safety to have your perspective and practice your perspective and respect others in that space.
But also just to add, you have to have you may have your own perspective of what you believe and what you could live with or not live with. I'm sure Jeff will get to my two-head theory, but I may not be able to live with the idea of it for myself or for my family, but I am a professional. We are professionals, and from my perspective, I'm going to do what I can do within the scope of my professional practice to the best of my ability. And if I can't fulfill that for a patient or a family, I will defer. But we respect each other, I think now. I really and truly.
Yeah, no, and you took the words out of my mouth, because the next slide was the two-headed syndrome. Did you want to explain anything more about that?
It's a little weird. It's just I had a moment many years ago when I was a family member in a hospital, and I was behaving like a lunatic to the nursing staff, like I just wasn't well behaved, and I realized I am like a regular family. I am just like a regular family. And then I could go to work and be like a social worker. And I realized I have two heads. And it was actually the most wonderful moment as a social worker, as a professional, where it dawned on me that I am able to carry two heads. And I'm able to learn from one head. Like I learned from my own life experiences and how I learned to live with loss or trauma or whatever. I use it as a tool to educate myself and to grow. So I transfer it to my professional life. But it is two heads, and I think it's like there's a moment in most of our professional careers where we go, holy moly, I have two heads. I'm like everybody else. I mourn, I cry, I behave badly, I stomp my feet. And then I am Brenda, the social worker, who hopefully behaves a whole lot better than that and kind of can see it, not always, and can see a different perspective. So just because I don't know if I could do what these people do, I've never been sick in a hospital. I had a baby. That's it. I've never been in this situation. I don't know what this walk is like. That's all there is. Like, so it's a different perspective, but I am a professional.
Thank you, Brenda. So a couple more questions and then we'll finish up. A person was asking when we were talking about, I think, the physical and mental underlying causes, would that be the same as someone with anorexia or bulimia, where mental illness causes the physical symptoms and death? Yeah, there was an unbelievably powerful piece in the New Yorker some months ago that was circulated. A woman with I think profound eating disorder, I think it was, Brenda, and it was the most impactful story. The bottom line is that anorexia, bulimia are considered mental illnesses, and so when that is the underlying condition, then a person would not qualify for MAID, even if they are at severe risk of death because of the underlying problems with potassium or what have you that can surface. So that's a tricky one. It's an excellent question, and I think that one gets us into the gray zone. What advice would you offer someone who would currently fall under advanced requests? So if you have an underlying illness that makes you eligible, but puts you in the track 2, then that is a route for a person who would want an advance request. If you don't have an underlying illness and you're just thinking about the future and wanting to maintain that sense of control that Brenda spoke about earlier, the advice I would give is make sure to empower your substitute decision maker with the kinds of information that would help them to make decisions, and ensure that you're not in, to the extent that they can, you're not in a situation where the image of life is actually intolerable for you. And so I would say that's what I would say. If you do have an illness, then track 2 is a route. If you don't have an illness, then you're SDM. Can a nurse refuse work, for example? Is a provider who objects also obliged to direct patients to info access care? So 2 parts to that question. Can a nurse refuse work? I don't know, actually. Brenda, do you know the answer to that?
I don't know.
Okay, so I would say talk to your manager about that one. Is a provider who objects also obliged to direct patients to info access care? That's a hard yes. We both have professional colleges, statements from our colleges that are very clear that we have a duty to ensure access to care if it goes against our personal and professional sort of values and value systems. And so yes, you must ensure a person has access to any care that you're uncomfortable with potentially providing. And I see Thomas has come on, and so that means it's time for us to stop.
You still have 2 more minutes if there's anything you want to wrap up.
Do you know, I will just put a final slide up for folks and encourage folks to self-identify blind spots, personal limitations. It's okay to feel unsure, but set personal limits. Remember that each case is unique. Refer for another opinion when appropriate or helpful. In the absence of a specific context, reflect on your personal values as they relate to reasonable foreseeability, and self-reflect and team reflect for any case, really, as opposed to complex cases. And apologies for the questions that we didn't get to in the chat. I see one that I can answer really quick. Can a client withdraw the MAID request closer to the date? 100% yes. Up until the moment before a person can withdraw their consent, for sure.
And we ask a lot.
Yes. Are you sure? Are you sure?
Every time I walked in the room, she went, yeah, C14 or whatever the bill is. Yes. Yeah.
And just as a quick anecdote, I've actually had one patient who changed their mind in the last minute, but then did proceed eventually. So it's not as common as you would think.
Okay, well, on behalf of Casey House and the OHTN and all of the participants, I really want to thank Dr. Jeff Myers and Brenda Stein for taking the time today to really, it felt more like a chat than a presentation. I really appreciate you answering all the questions or most of the questions and giving us some really great information and some things to think about as we move forward in our professions.